Hello, everyone. I'm Eileen Sullivan. I live in the Boston area, and I've had Waldenstrom's since 1995. I've also had extramedullary Waldenstrom's since about 2003, which is the focus of our program today. This is something that is very important to me, obviously, and we're happy to be able to have a meeting today with Dr. Shirley D'Sa, whom you'll meet in just a minute. I'm going to let Pete introduce himself. We're going to work our way through this program together.
Thank you, Eileen. I'm Peter DeNardis. I'm from near Pittsburgh, Pennsylvania, United States, and I was diagnosed with Waldenstrom's in 2003. I've had several rounds of treatment since then, and I do also have personal experience with extramedullary WN for a couple times in 2010 and 2016 with soft tissue masses. I'm also excited to hear of Dr. D'Sa speaking to us about this topic. So please join me in welcoming our guest speaker, Dr. Shirley D'Sa. She's a consultant hematologist and professor of hematology at the University College London Hospitals. She leads the UCLH Center for Waldenstrom's and related conditions and is internationally recognized for her expertise in WM, IgM-related disorders, and their neurological complications. Dr. D'Sa is a strong advocate for patient education and shared decision-making, and is committed to translating complex science into practical, compassionate care for patients and families. So those that have attended Ed Forums know exactly what that means. She distills complex topics into ways that we can all understand. She's been a frequent speaker and done webinars for us and also for the WM European Forums, and is a board advisor for the IWMF. At the last Ed Forum, Eileen Sullivan and I met with her and discussed about extramedullary presentations of WM. And she mentioned that she does have patients with that rare manifestation in different forms, and she agreed to be an expert speaker on the topic for us. So everyone, please remain logged in after this Zoom session, as after the presentation, the pre-recorded presentation and Q&A, we'll have a live interactive discussion session among attendees to share our experiences and provide support and guidance to each other. Welcome, Dr. D'Sa.
Thank you very much. It's a real pleasure to be here, as always, and thank you for asking me to speak on this topic. I will share my slides. I am, as in a moment, I'm based in London, in central London, but currently, actually, I'm in Stockholm, in Sweden, visiting my family. As many of you know, Sweden is the home of Waldenstrom, when he was doing all his work in this area. But yeah, it's a pleasure to be with you guys, and I hope we can demystify this topic and make it more understandable and less scary as well, actually. So I will share my slides with you now. Hopefully you can see that. So let me get going. I'm going to start off by talking through the concept of extramedullary disease in Waldenstrom, and where best to start than the, oops, let me get the right thing, by terminology. Many of you will know that you need to learn a new vocabulary to deal with Waldenstrom macroglobulinemia, and not least the term itself, the diagnosis itself. It's a mouthful. And I must emphasize that other than eponymous names like Waldenstrom, which is named after the man who described it, a lot of words used in medicine are not there to confuse people. They are rather there for us as professions to speak to each other in ways that are consistent and accurate. So if we look at the word extramedullary, what do we mean? Well, medulla is a Latin word meaning marrow or inner core or pith. Now, and this is exactly where the bone marrow is in all of our bones. And so it simply means, medullary means relating to the inner core of something. And extra means outside of that. And so that is why we talk about extramedullary disease as being disease that is found outside of expected areas. And I'll go into a little more detail about what that means, because Waldenstrom does not simply turn up in the bone marrow. Now, I'd like to start at this very point in my discussion to say that EMD, extramedullary disease, should not be immediately frightening to you. It doesn't mean things are disastrous or terrible. It happens. It's not as common as perhaps normal, if you like, Waldenstrom. But I've personally seen a lot of it in my practice. And it takes a little bit of a slightly different way of thinking about things. But in the end, I regard it as treatable as Waldenstrom without extramedullary disease. It's also important to know that we all get, whether we have WM or not, actually, we as we get older, we get aches and pains and we get various symptoms. And in the case of WM, most of these are not due to extramedullary disease. You can get aches and pains from arthritis, muscle strains, degenerative problems, and other health issues. And to be honest with you, most extramedullary disease does not cause pain at all. So why does it happen? Well, that is not clearly known or understood. Clearly, there's something has changed in the way cells choose to move around the body. Now, when we think about WM, we have to remember that it is a disease of the immune system, of immune cells, lymphoplasmacytic cells. And in normal life and function, these cells, by definition, move around the body. They tend to arise in the bone marrow, and then they move around the system, the body, to police. They have a policing role. They keep an eye out for infections and pathogens that may come in to the body, and they mount a response against them. They're also involved in looking out for any activity that happens in the body, such as a tendency perhaps to develop into a malignant process. And they often snuff that out. So they have many of these functions, but they don't do that, if you like, from their armchair. They do move around. And therefore, for me, conceptually, it's not a surprise that sometimes WM cells kind of form a niche in another part of the body and set up home there. So I think that is the best way to look at it. So most WM cells are found they're anchored in niches in the bone marrow. And for some reason, changes in the way they interact with their environment through signaling, the use of adhesion molecules, etc. This can loosen that attachment and enable cells to migrate to other areas and actually decide to remain there and then grow there. Now, one question that often arises is, does treatment cause the development of extramedullary disease? Well, it's difficult to be sure of that. I think what treatment does do, modern treatments, including targeted therapies, is that it improves outcomes in patients with Waldenstrom. And what that then means is that people live with their disease for longer than perhaps they used to 10, 15 years ago. And so we may well be witnessing a change in biological behavior that we may not have seen before. So in some ways, one could argue that treatment may lead to a change in the way that the cells behave. So in my mind, it's not a direct cause of extramedullary disease, but it may be that our existing treatments are more used to suppressing bone marrow-based cells. And the cells that leave the bone marrow are already better at coping with surviving beyond that environment. So it's not an easy, straightforward thing to answer, but in general, it is not cause of extramedullary disease. Develops later on in the course of the disease, but some people present with it quite early on. So there's nothing binary about this situation. What I would say EMD is not, and that is the following. It does not automatically mean it's aggressive. It does not automatically mean it's transformed disease, nor does it mean that treatment has failed. It is not either about a single bad mutation. I'm afraid things are more complicated than that in biology. And I'll go a little bit more into that detail. What we don't know is why some people get it and others don't. And that could be due to some subtle genetic diversity within certain individuals. Perhaps they have different ways in which their immune system surveils their body and therefore enables the escape of some cells to form clusters in extramedullary environments. Or there may simply be some random evolutionary advantage that happens that leads to the development of extramedullary disease. So we don't quite know. The other thing I thought I'd mention is because some points were put to me before by Eileen and Pete, which had been mentioned by the community and come up time and again. And that is the thing, what is metastatic disease as opposed to spread outside the bone marrow? Now, metastatic disease is actually a disease that's more suited to people who have solid cancers. And it more accurately describes a disease which has left the index organ and has moved to another organ. So if someone has prostate cancer and it moves to the bone, that is metastatic disease. If someone has breast cancer, it moves away to a lymph gland or the lungs or whatever. But when you think about the lymphoid system, it literally exists throughout the body. And so we think of it more as extent or pattern of involvement of the body rather than migration to other areas. Another question that comes up often is bulkiness of disease. If you have lumpy disease, it can certainly be bulky. But bulky disease refers to size rather than location. It usually means that the disease, wherever it is meant to be, usually, is larger than average. So some people develop very large lymph node, what we call conglomerates, because we are all born with nodes in certain areas, and those areas may become very expanded by the presence of lymphoma. And sometimes those lymph nodes become kind of so joined up that when you see them on a scan, they're just one big mass, if you like. It can also apply to a particularly enlarged spleen. And now the spleen is regarded as part of the lymphoid system. So it's not classed as extramedullary disease. So in other words, bulky disease refers to big disease that is connected to lymphatic tissue. And it can also be regarded, applied to bone marrow-based disease, because bone marrow-based disease can be very sparse or it can be very heavy. But to be honest, bulk is usually attributed to disease that's sort of lumpy. So if you have bulky disease in the marrow, we call it heavily infiltrated. But if you have bulky disease outside, but within the lymphoid system, we call it bulky. Now, in some lymphomas, there are sort of definitions of bulk, such as Hodgkin lymphoma or diffuse large B-cell lymphoma, where there's this thing about, if it's greater than 5 centimeters or 10 centimeters in a location, that is called bulky. And the reason for that is that sort of has implications for certain treatments, such as radiotherapy that's used after chemotherapy, etc. With WM, it's not quite as straightforward as that. But I hope that gives you a bit more of an insight into what bulky disease means. So the question is, can EMD be bulky? And can bulky disease be EMD? And the answer is yes. So if you have bulkiness, but it's not EMD, an example of that is large lymph nodes. So it's where disease should be, but it's a lot of them, they're big. But if you have small deposits in unusual tissues, that is EMD, which is not bulky. But if you have a large mass outside of expected tissues, then you have bulky EMD. So I hope that is, you need to think about perhaps a little bit elastically about how these terms link up together. So what are the common sites for EMD? In general, you can get disease in the skin or under the skin, the soft tissues. There may be disease in and around the lungs. Sometimes the kidneys or parts of gastrointestinal system can be infiltrated by lymphoma cells. Sometimes the bone can become infiltrated. We have certainly seen that in our practice and reported infiltrated bone disease in Waldenstrom for the first time. And sometimes, of course, it can migrate to the nervous system. And that is something we know of as Bing-Neal syndrome. And that is because the nervous system is not part of the immune system. And in fact, there's a barrier separating that So we should not find cells other than brain cells in the nervous system. But Bing-Neal syndrome is almost a separate topic because it needs different management altogether. But that is EMD in the CNS of Bing-Neal syndrome. There are also rarer sites that are affected by WM, such as the breast, the prostate, the liver, the gallbladder, the conjunctiva, in other words, these tissues around the eye and behind the eye, and also masses that can occur in muscles. And I've actually seen this happen in different patients. And talking about mutations, well, is it caused, what is the association between EMD and mutations? Now, I think many of you listening will know that the majority of people with WM have the MYD88 L265P mutation. That is regarded as almost as a norm. And that is what's called a somatic mutation. It's a mutation that happens in the disease cells, not the germ line, not the person's own normal cells. So it's a disease mutation. And yes, this mutation drives signaling and growth of the cells. And one could say, does it contribute to the development of EMD? Well, the answer is probably not, because most people are MYD88 mutated, but most people do not have EMD. What about CXCR4 mutations? About a third or maybe 30 to 40% of patients with WM have CXCR4 mutations, not necessarily in the beginning, but they may develop them later at points of relapse. And it's true, CXCR4 stands for chemokine receptor 4. And a chemokine is a scientific term for a molecule that's involved in in trafficking cells. In life, chemokines help our cells to move around as needed. So in theory, one could argue that CXCR4 mutations could be associated with greater chance of EMD. And some studies indicate that perhaps EMD is more common in patients with CXCR4 mutations. But this is not a consistent finding. And so we need to wait and see what further study and evaluation tells us. Because again, many patients with the CXCR4 mutation don't have EMD and never will. There's another topic that I thought would be very important to mention at this point, and that is the topic of marginal zone lymphoma, or MZL. Now, in the medical and pathological setting where we are making the diagnosis, marginal zone and Waldenstrom cells, they often look very similar, and they often have similar markings. There's a marking which we look for in the B-cell lymphomas called CD5, and there's a condition called CLL, chronic lymphocytic leukemia, and that is typically CD5 positive. But Waldenstrom and marginal zone are typically CD5 negative. So they kind of group together already as being CD5 negative lymphoproliferative disorders. And they have other similarities as well. Now, these are the kind of ways to help differentiate between WM and MZL. WM is typically a bone marrow disease. They often make IgM, frequently in quite a significant quantity, and the disease is often related to anemia, thickness of the blood, and IgM-related effects. Marginal zone tends to live in lymph nodes and spleen and other tissues. So it tends to occur at sites of immune activity. And in our bodies, we have a lot of immune tissues in certain areas where we are likely to encounter infections. So around the respiratory tract, around the salivary glands, the tear ducts, around the gut. There's a big sort of area called the omentum, which is a support structure for the gut, which is heavily, has a lot of lymphoid tissue in there, because the gut is a place where a lot of bacteria can enter the bloodstream. So these areas can be a focus for the development of this marginal zone lymphoma, because in response to certain infections, marginal zone can develop. And then you can get swellings and enlargements and so forth. Now, one of the other distinctions with marginal zone lymphomas, an IgM may be produced, but it's typically much lower level than WM. And symptoms tend to be more related to the swellings that present with marginal zone. So if you like, marginal zone and WM are accents of the same language. Both are slow in progression. One is mainly distributed in the marrow, but can be found in other areas. Marginal zone is usually found in the node, spleen, and lymph and other tissues, but less so in the marrow. The IgM is more frequent and common in WM, and usually doesn't always happen in marginal zone, and is often less at a lower level. Blood tests are usually more informative in WM and less so in marginal zone, but the treatments do overlap heavily, although they may differ in what's permitted in different countries. And in both cases, the control of the disease can be over a very long period using various therapies. So coming back to EMD per se, is it a predictor of what's called high-grade transformation? And high-grade transformation is when Waldenstrom disease tends to go up a grade in terms of aggressiveness. So first of all, transformation in Waldenstrom itself is an uncommon happening. And even if it does happen, it can be treated, but the treatment needs to be different to standard Waldenstrom therapy. So sticking to transformation, if that happens, it usually takes the form of rapid growth of cells, new symptoms that are quite quick in the way they develop, such as fevers and weight loss and a swelling that's visible. People often have, it's a manifestation of the high turnover of these cells, that you get marked metabolic activity. And when you look down at a biopsy, it's very clear that these are large, more aggressive cells. So EMD is not a reliable predictor of high-grade transformation. Elaine just told us that she's had EMD for many, many years, so she's a good example of this. But the reason there is this overlap, and doctors often think, could there be high-grade, is because high-grade disease can arise in areas that is just a bit random, actually. But so when someone has an extramedullary site of disease and it's newly discovered, doctors will tend to check, could there be high-grade? And this is often when, for example, a PET scan may be done to check whether there's high uptake. So there are red flags that make it more likely to be high-grade disease rather than the fact that there's just EMD, if you like. So when should one suspect EMD? So it's basically when the disease or symptoms present that are a little bit out of whack with what one might expect. So if someone develops a swelling in a muscle, for example, or a subcutaneous lump, and it's sort of changing fairly quickly, then yes, you would think our reaction would be to investigate that more with imaging and a biopsy. If someone develops rapid shortness of breath and you do a chest X-ray and you see a big effusion has developed, fluid around the lung, then you would think, is this extramedullary involvement? And that's something that happens not infrequently. Or if someone develops sudden change in their kidney function, and then when you scan them, you see a swelling of tissue that's pressing on the kidney system, you then wonder about extramedullary disease, or indeed neurological symptoms. So if someone develops central nervous system symptoms, then you wonder about Bing-Neal syndrome, which I mentioned is a form of extramedullary WM. So how do you investigate? Well, the first thing one does is to do imaging. And you can use ultrasound scanning, PET scanning, CT scanning, or MRI scanning. The choice depends on the system involved, because certain systems are better investigated using certain imaging modalities. And that decision is made on a case-by-case basis. The IgM in the setting of extramedullary disease may be pretty unaffected, because sometimes extramedullary disease cells are less likely to produce IgM compared to bone marrow disease. So don't be surprised if you find a change, but your IgM has been normal, because that is sometimes a feature of EMD. So having identified a focus of possible EMD, the next thing is to try and really confirm that diagnosis with the biopsy. And the biopsy, again, depends on, where the disease is, what the characteristics are, what the scans are showing, what the risk is of that image, of that location of disease. And this is something that, again, has to be taken as a case-by-case basis. There are ways of biopsying tissues in many, many places using imaging. And that is something that so-called CT-guided biopsies or ultrasound-guided biopsies can be very helpful. Our approach is to pursue a biopsy as far as we can. And in most cases, we manage to achieve that with specialist input of radiologists. Now, I've been asked this before. Once there is EMD and you have a awareness of EMD and you may have treated it, or most of the time one would consider treating it because it's maybe causing a problem. Do you then go on to screen for it later on? So as I mentioned before, when you first find it, you do go through a process of checking the location that's involved, but also screening the system for other sites. But in follow-up, I would say most people would not necessarily propose a program of screening. And I'll come on to that in a moment. You might push back and say, well, you've just said that the IgM may not change. And that is true. So one has to be very alert to things and consider what is the best thing and what is the best interest of that patient. But in general, regular routine scans are not undertaken. But I'll mention a little bit more about that in a moment. Certainly, repeat imaging is done in someone with EMD if there are new or recurrent symptoms. Then and usually one would start simple. So, for example, if someone has primarily lung-based disease, then yes, a chest X-ray can be done very quickly, and then progressing on to a CT or an ultrasound to see whether, if there's reaccumulation of fluid, whether that should then be drained. Or if there are organ-specific symptoms, then yes, repeat imaging. If there's discordance between symptoms and blood tests, then yes, imaging might be worth doing, or a change in clinical behavior. And how is EMD treated? Well, as I mentioned before, EMD does not mean this is automatically more aggressive disease. It doesn't mean that you've run out of options, and it doesn't mean that this is end-stage disease. So in general, when EMD has happened, or is happening or is present, generally it does require systemic therapy because it's not usually in an area that's just neat and tidy. It means that you have to kind of give another line of therapy that is systemic, that is going to deal with the disease wherever it may be. There is definitely a role for radiotherapy in many cases, especially where you need local control, and that is used where appropriate and in conjunction with radiotherapy consultations. The kind of treatment needed is also dependent on how quickly you need a response. If there's been a slow process, then you can act in a more deliberate way. If you need a rapid response because something is being pressed upon, you then may bring in things like radiotherapy. I would say surgery is very rarely used. It's usually something that's done from biopsy or to, for example, doesn't really count as surgery, but perhaps to extract fluid from around the lung. That is a form of surgery. You need to put in a drain. And then after you give treatment, then there's the process of monitoring symptoms and imaging. And the idea is really to get back control of the disease and cause relief and stability in the situation, a bit like when we treat symptomatic Waldenstrom, in fact. So what is the role of radiotherapy? Well, it's usually invoked when there are symptoms being caused by local extramedullary disease, such as pain. Now, that can happen sometimes. I mentioned earlier that pain is not usually a feature of EMD, and that is true. But for example, if you have an area that's pressing on a nerve, then that may be relieved by the use of radiotherapy. Certain areas such as the orbit, which is the section where the eye sits, if there is a buildup of disease in that area which is about to impinge, say, on the optic nerve, then we would consider radiotherapy to relieve that pressure. So yes, radiotherapy can be used and is used in those cases. Sometimes you may use radiotherapy after you've had systemic therapy, but there may be some residual area. Again, that is very much dependent on the individual. And what about research? How does general research in WM apply to EMD? Now, the thing about the research in this particular setting is it's quite difficult because EMD is a rather individual experience with different patients, so it's quite difficult to extrapolate from individuals or do specific research in this area. So much of the knowledge about EMD comes from specialist centers where a lot of patients are seen, where people then describe case series or case reports. And these can be very informative and very helpful. And actually, I would like to bring your attention to a report published recently by some UK colleagues, actually, in Cambridge, where they reported a number of patients who have Waldenstrom, as well as disease outside the bone marrow or EMD, people with even low or absent IgM levels in the blood. And these patients had involvement of skin or eye or orbital disease or Bing-Neal syndrome. And I think the message from this was that patients with this kind of disease responded rapidly and well to therapy, including targeted therapies such as BTK inhibitors. And many of these lesions actually improved within weeks, and responses were seen even when the IgM wasn't raised. So that was a very reassuring paper, actually, and very much in keeping with my own experience of EMD, where you could see responses to therapy using both chemotherapy, immunotherapy, in other words, rituximab as well, or targeted therapies, or a combination or a sequence, depending on what's been had before. So I guess what I would like to emphasize is that EMD reflects some sort of adaptation by the disease over time. It doesn't necessarily reflect danger, but it does mean that we need to think a little bit differently in those individuals. Monitoring needs to be more individualized, and imaging thresholds, i.e. use of scans, may need to be lower than normal. On the other hand, we want to avoid what is called scanxiety, because that is something that can cause a lot of concern. The use of scans, waiting for reports, etc., the uncovering of unexpected findings that are not of clinical relevance. And then there's the issue of radiation exposure. If one uses PET scans frequently, then there is a cumulative exposure of radiation. And the management focuses on the behavior of the condition, the EMD, where it is, what it's causing, the symptoms that people have, and the location. And I think one has to simply respond to this problem, not with fear, but in a practical way. So to conclude, EMD is not uncommon. It's very well recognized. One has to keep an eye out for it. And if it is identified, I think it's important for appropriate investigations to be carried out systematically with imaging, discussion with radiologists, with other specialists. Now, we have, for example, a pleural team in our hospital. So if someone has pleural effusions, we will discuss with them, we will ask them to do the instrumentation, and we will get them to continue to help us if drains are needed, etc. Most new aches and pains are not due to EMD, and EMD can occur with a normal or low IgM. So we mustn't rely on IgM alone. If you have new symptoms and your IgM is stable, it's worth thinking about what those symptoms are and discussing that with your doctor so that they can perhaps zero in on those areas. But it's important also to know that most treatments, and including modern treatments, are effective in the EMD setting, which is great. And I think also prognosis is better than most people fear. And that is my own experience. EMD is a challenge because it's different. You have to sometimes deal with anatomical compartments that need other specialists to be involved, but it's not insurmountable, is what I would say. And I think with that, I will conclude my presentation.
Thank you so much, Dr. D'Sa. I felt as if you were speaking to me the whole time because so much of this that you have shared reflects what I've been living with for over 20 years now. And I'm so happy to hear someone speak about all these different complications. And I really hope that the broader medical community in Waldenstrom's understands what you do. And so whatever you can do in the future to spread this message to the medical community would be very much appreciated. We're going to do our best to get this message out to the patients because we hear from people all the time that, you know, as you said, it's not as uncommon as people think it is, because it's often unrecognized. So as a follow-up question, is there anything more to be said about why IgM is not a good indicator for following EMD? You mentioned that, it just isn't. And maybe it's the bone marrow is better, because is IgM produced anywhere other than the bone marrow?
Yeah, I think it's not an absolute. So, I mean, I have seen patients whose IgM has risen, and then when we've searched, they have had EMD, not exclusively though. So it's very difficult to sort of attribute the IgM to one compartment more than the other. If we're going to borrow, I mean, I in the past treated a lot of multiple myeloma, and that is also a disease which produces a protein, usually not an IgM, but it was interesting that the EMD of myeloma was often less secretory as well. And it seems that perhaps when there's this biological shift that makes these cells move out of their usual home, they also seem to perhaps lose other skills not as a consequence, but along the way, such as being less productive of protein. But I must say, there are no absolutes. It's not a binary thing. It's not that one is this and one is that. As always, there's a continuum. That is the way biology works. It doesn't like really being pigeonholed. But in general, I think I have often witnessed the fact that people, when we discover something, they go, well, my IgM has been stable. How come? And in some ways, that has lulled us into a sense of, stability. We think, oh, everything is stable. But I think the key thing is to, first of all, be aware as a patient of what your symptoms are, because my sort of, I guess my mantra is that patients know themselves best because they live with their disease 24/7. And if they notice something different, my job is to listen and try and understand how that is different to what we have been following up, for example. And if it's out of keeping with the IgM level or the anemia, if it seems in a compartment, then it's my job to then just explore a little bit further as to what that could be. And that involves examining a patient, doing the due diligence, frankly, and looking into what's going on, and then following that up with more investigations as appropriate.
Thank you so much.
Dr. D'Sa, you mentioned that treatment doesn't actually cause EMD, but can it be said that the treatment could possibly enable EMD? You may have mentioned this, but since many of us had normal or low Waldenstrom's or IgM prior to treatment.
Yeah, I think one of the things about EMD, it has become more apparent, I think, partly because treatment for Waldenstrom has become more successful, which is a good thing. It's a success, actually, because Eileen, I know you've had it for many, many years.
But I didn't have it in the beginning.
Not at the beginning. There you go. So if someone has a disease for many years and you treat it from time to time successfully, so you induce another remission, what happens biologically is that it sort of comes back as a slightly different version of itself. Now, we have actually rather coarse, rudimentary tools to measure the return of the disease. So we can look at grayscale pictures, we can look at blood tests and so on. But at a cellular level, I think there's a lot happening. And in that sense, there is a degree of selection of cells that come back, and those cells that come back may have a tendency to be less likely to stay home in the bone marrow and tend to move away. So I think maybe one of the discussions is about selection pressure on a biological sort of way, as well as that, for example, the CXCR4 mutation that I mentioned, it can be a feature of clonal evolution. So some people may not be CXCR4 mutated to begin with, but when they relapse, they may develop a CXCR4 mutation in a subclone. And it may be that subclone, that new sort of progeny of the disease, that then has a more of a tendency to go abroad, if you like, and less of a tendency to produce the IgM. So I kind of feel it's down to biological behavior, but what we don't have at the moment is a way of actually delineating this in detail.
Thank you. So kind of follow up. So if is there a difference in the genetics or the biology of a patient who, let's say, presents with EMD initially at diagnosis versus someone who, 10, 15 years down the road exhibits EMD?
Well, my thought with that is always like, when did the disease actually start? Because I think, as most of us know, when there are many, I think there are like 3 clocks in WM, right? Initial clocks. The first one is when something kicked off and the first cell decided to go rogue. Okay, so that is a pre-diagnostic thing. No one has a clue about that. Nothing's being produced, nothing's detectable. The second thing is when the disease is picked up. Now, that is picked up when it can be picked up actually at the stage of monoclonal gammopathy of uncertain significance. Mm-hmm. It can be picked up when the patient is otherwise completely asymptomatic, okay, asymptomatic or smoldering Waldenstrom, or it can be picked up when the patient is symptomatic. So it may be that if you presented with EMD, you probably have had WM for some time, but it's just never come to light. And so, I think in that sense, I personally, if someone presents with EMD, I don't sort of go thinking, this is really worrying. I don't think that at all. I think this is the way it is. That's what I think. We do delve more and more into the genetics of the disease. That is a policy that's being developed by all WM physicians so that we can continue to understand the differences in the diseases and disease behaviors. So I dare say more information will come up, but the best way forward is to really try and study EMD cases in a uniform way. And, we have upcoming meetings in Europe, in Greece, actually, say, for the European Consortium. I'm very happy as well that a number of our American friends will be coming as well. And, this is the kind of topics that will come up. And I personally will mention this, as how do we form a group to pool cases of EMD so that we can kind of follow a similar path, so that we can max out on diagnostic information, genetic information, and try and decipher some of these mysteries, if you like.
Thank you. That's great. That's good to hear.
It's very good to hear. Yes, because when many minds get together, good things happen, right. Especially in such a rare situation as Waldenstrom's with EMD. You mentioned pleural effusions and scans and bulky disease. And I'm wondering if when patients are found to have significant bulky disease, we often hear that they get repeated PET scans and to assess the size of the lymph nodes or the spleen. And is there a protocol for the best way to follow bulky disease to determine whether or not it has transitioned into EMD? Are there particular, wouldn't ultrasound work for a lot of that with no radiation at all?
I think absolutely yes. I think anyone with EMD needs an individualized screening plan or follow-up plan. Mm-hmm. Because whole body imaging is very, in many ways, it's very tempting because you literally see the whole body. And PET scans, as many of you will know, there's 2 bits to it. One is the CT part where you get the anatomy. The other is the injection of radioactive glucose, which gives you the sort of activity of the cell metabolism. And the main use of that in Waldenstrom, and this is more like a consensus opinion, is if you suspect high-grade transformation. Mm. So, for example, if someone in my care had extramedullary disease, as an initial staging, we would generally do a PET scan, because we want to check, is there a high-grade element to that? Is there something that is more aggressive? And to be honest, the PET scan is the best way of showing that, because if certain areas light up quite brightly, we would then target those with a biopsy more specifically. But going forward, I think you're completely right. So if we find that the nexus of the EMD is the chest, we will focus on reassessing the chest, particularly if there are ongoing symptoms, or if we are specifically initiating treatment. And sometimes that involves physical drainage. I mean, I've had patients who've had to have indwelling drains, sometimes for weeks and months, actually. And in those cases, we often use ultrasound to check the situation. Sampling of the fluid is very important as well, because with pleural effusion in particular, the first thing you need to identify if there's an effusion is, what is the nature of it? Can you find WM cells in it? Or is it what's called a chylous effusion? And there is this part of our lymphatic drainage system called the thoracic duct, which is not anatomically really visible on a scan because it's generally a bit collapsed. But if it happens to be squashed by a mass of glands in the middle of the chest, then you can develop a leakage of this lymphatic fluid, or chyle, into the cavity. And when you actually put a drain in, it comes out looking like milk because it's fatty substance. So these things are important. This is part of the due diligence that one does to work things up. So in that individual, actually, draining and reviewing things can be done very effectively with an ultrasound. I wouldn't sort of rescan the whole person with a PET. Because that is a lot of radiation exposure, and it's just too broad. So I think the best thing is to get a broad look and then zero in on the areas of interest for follow-up. And ultrasound can be extremely good at that, especially within the abdomen, chest cavities, or otherwise, CTs, focus CTs, because the equivalent of there's background radiation everywhere. But for example, if you fly from London to New York, you'll get a certain amount of background radiation. If you have a PET CT scan, a CT scan of your neck to the pelvis, it's like 150 flights from London to New York. If you have a PET CT, it's more like 250 flights or 300 flights. So if you need imaging, of course, it's important to do it. But if we're using it for screening, most doctors would be reluctant to be too free and easy with X-ray heavy imaging techniques, because cumulatively, we're not doing people a favor, perhaps. And, it also, perhaps even more so when someone is very young, you don't want them to be growing up having lots and lots and lots of PET scans, but for any age. So that is generally the approach we take. It's to be relatively conservative, to work very closely with radiologists and other specialists so that we use the right modality to image. But at the end of the day, the clinical features are also really important. And that's where the clinical medicine comes in, examining the patient, seeing how they feel, seeing what their, exercise tolerance is, all that sort of stuff.
Thank you so much. It's great.
Thank you. You mentioned different types of treatment as possibilities for EMD, including radiation, localized radiation and surgery, and possibly some other form of chemoimmunotherapy or BTK inhibitors. Is there a recommended first-time treatment? Let's say, is radiation and surgery enough, or would you add the BTK inhibitor after that?
Well, I think, to be honest, surgery, I think, is very rarely used beyond perhaps positioning of a drain or to get a biopsy. But as a fix, it's very rarely used because it's just, we don't really cut out hematological diseases. just not how it works, because they're everywhere. Our immune system is everywhere. Radiation-wise, I think it's mainly, so radiation focuses on the area of trouble. It doesn't cover other areas. So it's not something that can be used beyond the problem area. And it's used sparingly and in an appropriate dose so that surrounding tissues are not damaged. And that, again, that is the job now, certainly in the UK, of clinical oncologists. They're the ones who specialize in delivery of radiation therapy. And they will carry out very careful calculations as to how much to use and how to use it and how to protect other organs. In regards to systemic therapy, I think that is what is generally used when someone has the development of EMD, even if it's in one compartment. Because what it represents is that the disease has sort of moved on and it's now become more active. And so you can't just sort of say, okay, we're just going to treat, this area. We treat the whole disease. And to be honest, there are no fixed guidelines for EMD because it's not common enough and uniform enough. Mm-hmm. And anatomically, one has to be a little bit aware of what you're trying to achieve. But chemoimmunotherapy and targeted therapies like BTK inhibitors would be used depending a little bit on where the patient is in their journey. So if EMD happens in a setting where there's already been a lot of use of chemoimmunotherapy or very recent chemoimmunotherapy, the options would be to use what we call a non-cross-reactive regimen, so something that's different to what's been used before. It's a bit like antibiotic resistance to overcome whatever's come back has really not stayed away with that previous treatment, or to switch treatment to something like a targeted therapy, such as a BTK inhibitor, or increasingly other things like BCL2 inhibitors, etc. So it depends on the history of the patient and what they've had before, the rate of change, and as always, what else is going on with them? What is their general health like? Our own my experience has shown, I was very pleased to read the Cambridge paper because clearly, BTK inhibitors work well. I think we've seen variations of outcomes. So we have had some patients with EMD that I've instinctively felt should have chemoimmunotherapy, and they haven't responded that well. And when we switched them to a BTK inhibitor, they've been great. And I've had the opposite, where we've said it's time to use BTK inhibitor because perhaps they'd had a chemoimmunotherapy before, but actually it's just not done what's needed. And therefore we've had to switch them to chemoimmunotherapy. So there's no magic menu or formula. It is very much down to the individual case, but we also look for, whenever we can, for the genetic markers to see, does that shed any light? We discuss with colleagues to sort of think about what is the best thing to do in this particular case. So it is a directed, individualized plan that we have to give to every EMD patient.
Thank you. And if, let's say you have a, normal EMD patient that has low levels of IgM and everything else is fine except for the EMD masses, and they're on a BTK inhibitor and it works, do you continue with the BTK inhibitor forever or do you consider stopping it?
So I think if the EMD has emerged in the presence of the BTK inhibitor, that does represent the fact that the BTK inhibitor is no longer holding the disease, to be honest. Mm-hmm. Now, I think there are not many places where you can simply add things to a BTK inhibitor. One might think, well, if it's holding the bone marrow disease, why don't we continue it for that and add something on top and so on? Certainly in our practice, we cannot do that. I think most people would consider that at that time, for that patient, things have moved on and we need to use something different. I think as a principle, that is what most people would do. Perhaps it's another BTK inhibitor if you can access it, but probably a switch to a different modality of treatment altogether, I would have thought.
Right. But if it works, do you stay on the BTK inhibitor?
Yeah, absolutely.
Okay.
As things stand, in Waldenstrom, BTK inhibitors are long-term continuous therapies. There are trials underway right now looking at combining them with BCL2 inhibitors, etc., in a way that enables us to give more a combination and allows us to stop everything. because treatment-free intervals, I think, are very valuable, and most patients really do value them. But these are trials. We need to wait for some results before we do that, see what's the best thing to do.
Thank you.
Thanks so much. Going back to the topic of pleural effusions for a moment, if we could. You mentioned that you're going to analyze the fluid to see whether or not it's from the blockage or is it LPL, Waldenstrom. If it does the treatment and the follow-up differ in the depending on what it is that you find. If it's from a blockage, then what do you do? If it's from Waldenstrom, how does that change anything, or does it?
Yeah, that is a good question. I do remember a case within the last couple of years where we found this so-called chylous effusion, this blockage effusion, the one that results from a blockage. And it was actually very tricky we were trying to see, could we find where the blockage was happening? But because this thing, what I call the thoracic duct, is not anatomically very visible, it was not easy to sort of figure it out in detail, even with cardiothoracic surgeons looking at imaging and so forth. In the end, it basically did resolve or stop with treating the underlying disease. And so at the end of the day, one has to simply treat the disease, because whether it's squashing that duct and causing seepage of the fluid, or whether it's causing, if there are cells that are seeded in that area, you still have to treat the underlying disease. You have to put weed killer on the weeds, if you like, because that is the way to really turn off the process. But yeah, some cases it's quite, if you have a cluster of glands that you can visibly see on scans pushing on what we think is a thoracic duct, that could be a time when radiotherapy to that area would be useful. But the context would be systemic therapy as well. It's very unusual for just to say radiotherapy will do the trick.
Thank you.
And in your discussion, you mentioned similarities between WM and marginal zone, especially when EMD is involved. Is it possible, and you may have mentioned this, but is it possible for someone to have both diagnoses? Or does that mean they just haven't clarified what exactly it is? Like, how would you distinguish between one versus the other?
Yeah, I think it's probably just the gray zone, to be honest. We've certainly got patients who've got CLL and WM, and that's quite easy to distinguish between the two. And actually, one needs treatment, one doesn't sometimes. So, but with marginal zone and WM, I think it is usually a gray zone entity. And the way we do, because the treatments are very similar and crossoverable, we tend to use the diagnosis, we tend to use a term to our advantage, because in certain countries, marginal zone has permission for certain treatments, as opposed to Waldenstrom, and vice versa. So we would sometimes say, okay, in order to give this treatment, we're going to call it this, or the other way around. So to be honest with you, I think they are, as I mentioned, they're like different accents of the same language. So I feel fundamentally that when someone has, if it's marginal zone or Waldenstrom, giving either chemoimmunotherapy or BTK inhibitors, neither of them are wrong. And so we tend to make a decision based on what we feel is predominantly the problem, but actually the treatment choices are very similar, actually, in the end. I mean, the only other thing that is a bit different with say, marginal zone is there are 4 different entities, actually. One is called nodal, one is extranodal, one is splenic, and one is, there is a 4th. Anyway, the splenic one typically causes a very big spleen, and you can actually take the spleen out in certain patients, and that is very helpful. So in those circumstances, it's useful to make that distinction. And so the crossover is such that you can cover both conditions with very similar treatments.
Thank you.
So now we're coming to the end of this presentation, but as a last question, we're thinking about the future and wondering whether or not things like CAR T therapy might be useful for this, or are there other things on the horizon that we should be keeping our eyes on for the next few years?
Yeah, the good news is yes, 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 because there are so many trials ongoing in Waldenstrom, which is actually remarkable given that it's a small disease. And I think that is testament to the cooperative nature of the physicians who work really well together.
Mm-hmm.
And also borrow from evidence in other areas, other lymphoma types. I think the next big thing is the BCL2 inhibitors. So it's like sonrotoclax. There are trials ongoing with this, and there are new ones in process combining BTK inhibitors and sonrotoclax, as I mentioned. There are other incoming antibody treatments called bispecific antibodies, which they're somewhat more advanced in some diseases than they are in Waldenstrom. But for example, myeloma, there's a very wide use of bispecifics. Now, bispecifics are antibodies. So rituximab is a monospecific antibody. It's manufactured to target B cells by hitting on CD20 and helping the immune system to kind of kill off those B cells. And as you know, we usually give it in conjunction with chemotherapy. Mm-hmm. Bispecifics are specially engineered to target two things. One is the disease, B cell. The other are the T cells. And by getting the B cell and the T cells together, it really helps to make those T cells get rid of the B cells. Because at the end of the day, cell kill through antibodies is using the immune system. Now, bispecifics are making amazing headway in the setting of myeloma and in other lymphomas. There are trials launching in Waldenstrom of bispecific antibodies, including drugs like epcoritamab. They are mAbs, being antibodies. Mm-hmm. I think those are truly exciting treatments. I've seen them in myeloma because I do cover myeloma when I'm on the wards. They're really, really remarkable. And I do think they will probably be ahead of CAR T utility going forwards. CAR T has a great utility in more aggressive diseases, such as leukemias and high-grade lymphomas. And perhaps in due course, it can be applied. And there is evidence in some Waldenstrom settings for CAR T therapy. But I feel as if the bispecifics are going to kind of come and take over, if you're thinking about a road of progress. So I think personally that is probably what will happen. So bispecifics are almost like, they do similar things to CAR T, but they're an off-the-shelf product. CAR T is something that has to be made per patient because you take cells from the patient, you engineer them and you put them back. And that is often quite difficult to achieve in a more low-grade condition, and also the toxicities are more unpredictable. Mm-hmm. So I think the very broad answer is there's a lot going on. I think the important thing is for EMD to be included, or rather not excluded from clinical trials. And people like us often voice this when trials are being considered, because there are often cutoffs for IgM levels and bone marrow, this, that, and the other. But I always point out that conditions like Big Neal and extramedullary disease, they deserve, and people who don't have an IgM, the few people with WM or lymphoplasmacytic, they need to be included in trials. And I think companies understand that more. So I think all these things should apply to EMD patients as well.
I'm so happy to hear you say that, because as Pete and I know, we're not eligible for clinical trials because our IgM is not high enough, and so there is nothing to measure in a way to show that you have achieved success. And so all these trials will be wonderful if they apply to WM in general. That will probably be of significant benefit. But you're right.
Yeah,
don't include us.
We do need to push for that. And I think the more EMD is recognized, and I think there's going to be more and more recognized because people are living longer, as I mentioned, and they live with their disease for longer and the behavior can change. Imaging is actually rightly or wrongly, it's more frequently done for various things. So I think if we have a more directed approach to following up on symptoms that are a little bit atypical, we should most certainly include patients with EMD. And I think this is certainly a message I put forward to companies when they're planning their trials. The other good news is that, FDA and organizations like that require patient involvement in the development of clinical trials. So if that in the WM space, I think it's really important for that sort of voice to be heard, that EMD is important. There's an unmet need. And from my perspective, that is something I will always do, is to push forward the subsets, because they don't have a lesser need to the typical population.
Right. Thank you.
Thank you. Thank you, Dr. D'Sa, for taking the time out of your busy schedule to talk to us about this topic. I know, at least for myself, and I don't want to speak for Eileen, but I feel much more comfortable with the notion of extramedullary disease and have a better understanding of it. And I hope other patients out there won't be quite as scared about it when it does occur, but they will know what to look for. And it's your being an advocate for us is truly commendable, especially for those of us that have rare manifestations of a disease like this. I can't thank you enough for doing that. And we look forward also to seeing you at the next Ed Forum in Columbus, Ohio.
It's my absolute pleasure. Honestly, it's always a pleasure to talk to you guys and to spread the word about Mission WM. It's something that is very close to my heart. So thanks for asking me. I look forward to seeing you too. All the best.
Thank you so much.
So I just want to say for everyone else, stick around after this presentation. We'll have a interactive support group session for everyone in attendance. And hopefully we'll have some lively discussion.
And one last shout out to Shelley Postic, who is our behind the scenes IWMF staff member, who has been recording this and helping us get this all set up. So thanks so much to Shelley.
Yes, and I don't want to be remiss in giving Eileen the credit for being the champion for this topic. She would not let it go, and I'm glad she did that. You have her to thank for this being made possible.
Thanks, Pete. We're a team.
Yes, okay.